Welcome to Module 2 of the Palliative Care COVID-19 webinar. In this module, we will be covering whole person approach to symptom management in a COVID-19 environment. By the end of this module, we hope that you will be able to describe the whole person model when assessing a patient who is infected with COVID-19. List the common treatment methods for dyspnea, anxiety, agitation, and secretions for patients with COVID-19. Describe the symptoms and distresses at end of life and ways to address them, and recognize need for clinician self-care in the moment and promote resilience in yourself and others. Let's begin by introducing Margaret, who is a 74-year-old who has lived in a nursing home for about 10 years. She has adult onset diabetes, asthma, and obesity. She has a daughter, Reba, who lives locally but has not seen her mother in 3 weeks because of social distancing. She has been in contact by telephone. Margaret's Catholic religion is very important to her. She is described by staff as having a big personality and enjoys leaving her room to socialize with staff and other residents. Margaret has tested positive for COVID-19, and over the past 4 days, she has developed a dry cough, a low-grade fever of 100.5, and is hypoxic at 88% on room air. What needs do you anticipate as Margaret faces COVID-19? Think for a moment. Write a couple ideas down. I'll give you a few minutes. Before we can talk about what we can do at the bedside, let's take a step back and talk about whole person care. My colleague Bronwyn will walk you through the next few slides.
As palliative care and hospice practitioners, we approach symptom management during the time of COVID from a whole person perspective derived from the work of Dame Cicely Saunders. Saunders understood the human experience as complex, encompassing all domains of personhood: physical, psycho-emotional, social, and spiritual. In this model, each domain is equally important and indivisible from the others, and what happens in one affects the whole person. Throughout this webinar, we will be attending to all domains of both the person infected by COVID-19 and their caregivers. The intensity, uncertainty, and longevity of disrupted routine in life under COVID-19 have placed extraordinary stress on us all while weakening our usual sources of support. Physically, the novelty of this virus strains both patients and clinicians. Not only is an individual's prognosis radically uncertain, but at this time we lack clear treatment options for cure or control of the virus. Psycho-emotionally, we can recognize that uncertainty is cognitively expensive. Add on relentless media coverage, the need for constant vigilance, and the scale of our incapacity to control what is happening to and around us. And we may find ourselves exhausted, emotionally dysregulated, and possibly needing to navigate traumatic stress. Spiritually, the pandemic nature of COVID-19 has disrupted not only meaning and purpose at the individual level, but stripped us of the communities and rituals many people rely on for making meaning and spiritual and emotional renewal. Communities experiencing high losses risk not only traumatic bereavement, but moral distress. Socially, self-isolation, social distancing, and masking inhibit the spread of the virus. They also deprive us of some of our most fundamental sources of well-being: the presence of others, the opportunity to share our stories in person, and touch. Recognizing the stresses in all of these domains can make us more effective as we care for our patients and each other.
Next, we will discuss the whole person approach for key COVID-19 symptoms. Let's go back to Margaret. Margaret is now reporting to her nurse that she cannot catch her breath. Her respiratory rate is 18, and now she is more hypoxic and tachycardic. She is also using accessory muscles in her neck, chest, and abdomen to breathe. Margaret is currently found to be hunched over her bedside table in the tripod position. How might you respond to Margaret's new shortness of breath? Write down one way you would respond in this moment. Next, let's take a look at assessing and responding to Margaret using the whole person approach. Let's hear from my colleague Sue.
Severe and sometimes milder disease in people. Pulling from the whole person approach, the following are primary responses that you can do when a patient is experiencing dyspnea. You can communicate calmness non-verbally when you enter the room. One example is to try slowing down before you enter the room. Oxygen can be a useful response for patients with hypoxia, as this can help increase airflow and improve comfort. However, oxygen may be an extra tether for some patients and can increase dryness in the mucosal area. Repositioning a patient to the sitting position can improve airflow. Pillows can assist in supporting a comfortable position. Clinician might use diuretics, bronchodilators, to assist with opening up airways. Opioids can also be beneficial with these medications to help to ease the work of breathing. For mild symptoms, we suggest morphine, 5 milligrams PO every hour PRN, or 2 milligrams IV or sub-Q. For moderate symptoms, we suggest morphine, 10 milligrams PO every hour PRN, or 3 milligrams IV or sub-Q. For severe symptoms, we suggest morphine, 4 milligrams IV or sub-Q every 30 minutes PRN. If the patient's allergic to morphine, you can substitute oxycodone or hydromorphone. Some additional responses to think about. Improving the airflow in the room with a fan is important in response to dyspnea, but in COVID-19, this can increase the spread of droplets. Fans are not recommended. If at home and at a location that can open a window, this could be helpful. Note that nasal cannula oxygen, or even just air through a nasal cannula, stimulates the trigeminal nerve, which can have the same effect as a fan. Relaxation techniques and mindfulness can be helpful as well, just as validating that breath is primal. Some things that you might say are, I see you're working pretty hard to breathe. I will stay with you until you are more comfortable. This can validate their emotion and show your support. Or maybe, I'm hearing how helpful your daughter's support can be. Would you like for me to call her and set up a video chat right now? This assists in making connections to a support person or loved one. Before we continue, let's talk about some misconceptions when using opioids for patients with dyspnea. Think about whether each of these answers is true or false. Morphine is the best opioid for dyspnea. That is false. All opioids can aid in dyspnea. Morphine, however, is much cheaper than the others and is more readily available. We do recommend using hydromorphone or oxycodone when someone has a severe renal or liver disease. Opioids expedite the dying process. That is also false. This is a common concern by patients, families, and clinicians, and it is not true. Opioids, when dosed appropriately, do not expedite death, and sometimes when patients have their dyspnea well controlled, they actually live longer. Margaret mentioned to us that she was worried that morphine would kill her, and so educating patients, families, and our colleagues can be important in this. Oral concentration morphine is absorbed sublingually. That is false. Morphine has to get to the GI tract. It does need to be swallowed or trickle down the back of the throat. It is not absorbed buccally through the cheek. Fentanyl is the only opioid that can absorb buccally. Opioids at the end of life are most commonly given for pain. That is false. In fact, only 20% of patients we believe experience pain at the end of life, mostly in cancer populations. Dyspnea is common in nearly 70 to 85%. This is probably even higher in the COVID setting. Morphine and hydromorphone can be given subcutaneously. That is true. They are available in both IV and sub-Q form. There may be times when the sub-Q route is more optimal. Sub-Q reduces the time to peak effect for medications which have been helpful in symptom management with COVID patients. Let's talk more about sub-Q and how to gain subcutaneous access. Common indications for sub-Q use. Circumstances that preclude or compromise oral administration, such as difficulty swallowing, intestinal obstruction. Decreased level of consciousness or coma, excessive oral secretions, ineffectiveness of PO or sublingual, or acute symptoms requiring rapid and reliable medication administration. Some things you should know about using sub-Q. The subcutaneous medication absorption rate is only about 1 to 3 milliliters per hour, as this is limited by the subcutaneous space. You may need to use 2 separate access sites if you are going to exceed the absorption limit. Note that the time peak effect is between IV and oral peak effects. Let me demonstrate for you how to prime and access a sub-Q site.
So to insert a sub-Q set, you'll need this appropriate supplies. We are using this Clearview sub-Q set that looks like this. You'll need a clave cap, which you will be putting on the sub-Q site itself. Of course, we're going to be doing hand hygiene and gloves. You will need the medication to be primed for this sub-Q site. So you'll pull up the medication in a 1 cc syringe, and you'll prime the sub-Q set with the medication, which is different from an IV. So you'll prime it until you see the medication come out at the bottom of the needle. You'll be prepping the site with alcohol, and you will be putting the sub-Q site directly into the subcutaneous tissue. We withdraw to make sure there's no blood return. If there is, you're in a vein, and you'll want to remove the set and put a new one in, a different site. You'll secure this with Tegaderm, and you'll write on the sub-Q site what the medication is for. This one's for morphine, so I put an M. When you give the medication, you go very slowly and make sure there's no leaking of the medication at the site. And you can loop it around and put a piece of tape to secure the tubing if you need to.
Anxiety and dyspnea are interrelated and can sometimes exacerbate one another. When assessing a patient who has dyspnea, you might also notice that they are expressing fear or worry, or you might see them fidgeting or clutching objects like rosary beads or personal objects that are comforting to them. Key responses to the anxiety component of dyspnea can be treating the dyspnea. The anxiety can improve when a patient feels less short of breath. You can also maintain a calming presence at the bedside, and if necessary, offer medications along with the opioids such as anxiolytics. We suggest using low-dose lorazepam. This should never be used as first-line therapy for dyspnea. Patients who already take medications for their anxiety disorders should have their meds continued. The following is how you can reassess and titrate your responses in dyspnea. Step 1. Check back in with the patient after peak effect of med, which is about 45 to 60 minutes for oral doses and about 15 to 30 minutes for IV dose. Does the patient say they have improved? Do you see a decrease in accessory muscles and softening of their posture? Are they having decreased anxiety? Step 2. If ineffective after 2 doses, increase the PRN dose by 50 to 100%. For example, a 5 milligram dose would be moved up to 7.5 or 10 milligrams, and then repeat if needed. Use that dose that had the best response for future PRNs. Step 3. If the dyspnea is anticipated to be continuous and/or predictable, consider scheduling the dose that you titrated to every 4 hours and add an additional PRN dose that represents 10% of the 24-hour total. For example, if they were taking 5 milligrams every 4 hours, the total would be 30, and therefore the PRN would be 3 milligrams.
Back to Margaret. Overnight, she has spiked a fever of 101.2. She was found by the LNA trying to get out of bed, which was unusual for her. She also seemed distressed as she told the night nurse that there were frogs at the end of her bed. How might you respond to her agitation? I will give you a moment to think about it. Let's see how your answers compare to some suggestions my colleague Colleen will explore with you.
Let's start by defining anxiety versus agitation. Anxiety, as heard earlier in the module, is a feeling of fear, worry, or panic, while agitation is an inner restlessness. Your sensorium is off and you're disconnected with the world. Agitation can be a symptom of delirium. You might remember that delirium is defined as an acute change in mentation where someone can be easily distractible, disorganized in thought, and experience perception disturbances. In COVID-19, delirium occurs along with fever and/or hypoxia. It can often be an indicator of a steep decline in the COVID trajectory. Patients who are experiencing agitation in the setting of delirium might tell us to leave them alone or plead for help. They may ask family who are not present or see things that are not there. When assessing a patient, you might see them yelling or crying or pulling at their tubes or trying to get out of bed. This can appear as if someone is trying to crawl out of their own skin. This is a distressing symptom to witness, and if patients are partially aware of it, it can be extremely stressful for them as well. Noticing early signs of delirium can help us prognosticate and anticipate needs more effectively. Here are some suggestions for responding to distressful agitation. Responding to people reporting hallucinations can be challenging. The yes and approach affirms what they are experiencing for the purpose of meeting patients where they are and helps determine whether the experience is welcome or scary. Trying to reorient the patient to a reality, while a common response, can be disturbing for the patient and actually worsen agitation. If in a hospital or facility setting, reconsider waking up for timed vitals, lab draws on a case-by-case basis. It's important to limit disrupting noise during sleep as well. If non-pharmacological responses are insufficient, medications can be used to help reduce the agitation. A common misconception is that Ativan is a first-line response to agitation. Unfortunately, studies have shown that Ativan in fact can increase agitation unless they're in alcohol withdrawal. Instead, we recommend using antipsychotics such as haloperidol. For mild symptoms, start with 1 milligram PO or 0.5 IV or sub-Q every hour as needed. For moderate symptoms, you're going to increase to 2 milligrams PO or 1 milligram IV or sub-Q every hour as needed. And then for severe symptoms, 1 to 2 milligrams IV sub-Q every hour as needed, especially when they're at risk for harming themselves or others. Additionally, we suggest avoiding physical restraints as well as anything that might feel physically restraining, such as catheters or IVs. We suggest keeping soft lights on during the day and lights off at night, and maintain a calm environment with the help of music, or you could turn on a TV to a comforting station. While working with agitated patients, you can provide support by saying, "I see this is hard. May I sit with you?" If the patient is experiencing hallucinations, as in our case when Margaret reported seeing her frogs, you can use the yes and approach by saying, "I'm so glad you told me about the frogs on your bed. Can you tell me more about what you see?" If you have given medications for agitation, the following steps will guide you in reassessing the titrating medications if necessary. Step 1. Check back in with the patient after peak effect of medication. 1 hour for oral and about 15 to 30 minutes for IV. Look for whether the patient exhibiting less agitation or delirium, or is the patient quieter, calmer, better able to engage? Does the caregiver report patient's behavior is closer to baseline? Step 2. If the medication was not effective, you can repeat the same dose. If that dose doesn't help, you want to increase the dose by 50 to 100%, 1 milligram to 1.5 to 2 milligrams. If Haldol is effective, use the dose that you titrated to every 4 hours as needed. Add olanzapine or risperidone if persistent for greater than 48 hours or if refractory to haloperidol. You can still use the haloperidol for breakthrough agitation if using olanzapine or risperidone. Step 3. If none of these are effective or you do not have access to olanzapine or risperidone, you can use lorazepam, particularly if there is an anxiety component. Note that lorazepam may also cause paradoxical delirium in older patients.
Checking in with Margaret, it is now 2 days later and she has declined in her functional status. She is spending most of the day in bed. You have also controlled her symptoms with 4 PRN doses of morphine for dyspnea and 2 PRNs of haloperidol for agitation. A staff member today noticed that she has had new secretions and increased cough. How might you respond to her?
Excessive secretions may be significant in severe COVID-19 infections. This is most likely to be a concern when the patient is in the dying process and unable to actively clear secretions because of lost reflexive swallow. Caregivers may express concern that the sound of the secretions means their loved one is suffering or drowning. Caregivers may also be distressed that these secretions indicate that death is near. When walking into the room, you might notice frothing from the mouth or nose. Secretions can be thick or thin, and the sound, sometimes called the death rattle, is obvious and can be disturbing even for those who are familiar. Primary responses to secretions include repositioning the patient, especially propped on their side to allow for postural drainage and opening the upper airway. Good mouth care is an important part to secretion management. You can place chapstick or lip balm on their lips and use mouth swabs to clean their mouth. These measures can be scheduled every 1 to 2 hours so it's not missed or overlooked. Gentle oral pharyngeal suctioning is good, but try to avoid deep suctioning in dying patients. Medications do not eliminate secretions unlike repositioning and suctioning, but they can prevent further secretions. We recommend using the following medications: glycopyrrolate, 0.2 milligrams to 0.3 milligrams oral or sub-Q IV every 4 hours as needed or scheduled. This is a good first-line agent as it does not cross the blood-brain barrier and increase delirium. Atropine, 1% ophthalmic solution, use 1 to 2 drops oral every 4 hours as needed or scheduled. Or scopolamine patch, 1.5 milligram patch every 72 hours. Use this only in severe and refractory cases as it takes 12 hours onset and can cause increased delirium and sedation. Some additional responses can be limit fluids introduced into the mouth and switch oral sublingual medications to other routes. Limit or stop IV fluids and enteral feedings. If these responses aren't effective, the best response is education and reassurance to family that the patient is not suffering and that the noise is a natural part of the dying process. You can reassure caregivers with the following statements. This is often more bothersome to you than to them. I hear that you want to do something to care for your mother. May I offer a suggestion? If you have responded to a patient's secretions, the following steps will guide you in reassessing and titrating medication if necessary. Step 1. Check back after your initial response, minutes for repositioning. It would be hours for meds. Does the patient have decreased sound or amount of secretions? Is decreased distress for caregiver? Step 2. If they have not improved with the repositioning or your medications, consider limiting additional fluids and/or switching oral meds to IV or sub-Q. Schedule of secretions are continuous. You can also increase glycopyrrolate and atropine doses by 50 to 100%. You might also want to schedule repositioning if comfortable for the patient. Step 3. If persistent, educate and reassure caregivers. You could mention to caregivers that the death rattle is where secretions sit on top of the vocal cords and rattles. A person no longer has the sensation to clear them. You can also offer that they participate in oral care or ask them how they may want to participate in care for their loved one.
10 hours later, Margaret is hypoxic, has a temperature of 103.1, frothy secretions, and has minimal urine output. She's now unresponsive to voice. When the doctor called her daughter Reba with this update that Margaret had continued to decline and mentioned that she was worried that Margaret was not going to survive, Reba expressed a desire that she wanted her mother to be comfortable and also that she wanted to be able to talk to her. How do you provide comfort, focused care for both Margaret and her daughter Reba? I'll give you a moment to think about this. Let's look at how we can take the whole person approach to COVID patients at the end of life. Let's hear from my colleague Steve.
Before we talk about the assessment and responses to patients at the end of life, let's go over some common misconceptions. I will review a statement, and I will ask you to think about whether this statement is true or false. Statement 1. All patients need to be sedated to be comfortable. False. As long as symptoms are well managed, patients can be comfortable at the end of life without receiving dosages that are sedating. We medicate to the point of comfort and not sedation. For example, for opioids, dyspnea doses can be about a quarter of the amount of doses it would take to sedate someone to be comfortable. Next statement. One should look for accessory muscle use when they see agonal breathing before they increase doses of morphine. True. Agonal breathing is a natural part of the process of dying and may not cause discomfort. Therefore, without accessory muscle use, there's no benefit to medicate for agonal breathing alone. However, it can be hard to watch. Education or reassurance is key. Next statement. If a patient is agitated, the first line medication is lorazepam or Ativan. False. As we mentioned earlier in the module, a common misconception is that Ativan is a first-line response to agitation. Unfortunately, studies have shown that Ativan and other benzodiazepines, in fact, increase agitation. Haloperidol is the first-line agent recommended for agitation, while Ativan, or lorazepam, is good for anxiety. Next statement. A person on comfort measures only cannot receive hypertensive meds or blood sugar checks. False. Patients who choose to have comfort-focused care are not excluded from receiving their prior medications, even their blood sugar checks. The goal here is to focus on comfort, and sometimes that can include medications, lab tests, and even vitals that are aimed at symptom control. For example, high blood pressure or high sugars can be bothersome to some patients. Note, we no longer use the term comfort measures only, or CMO, because it does not recognize each individual's trajectory and values. Comfort-directed or focused care is the term that can encompass the gray areas of end of life. A person who has a respiratory rate of 36 is not using accessory muscles, requires additional medication. False. Remember that respiratory rate can be variable depending on physiological conditions, such as acidosis or increased intracranial pressure, which create increased respiratory rate. And treating the reduced respiratory rate alone without signs of increased work or breathing is not clinically indicated. As clinicians seeking to provide dignified end-of-life care, we should keep a dual focus on the needs of both patients and caregivers. With our patients in sight, we can be attentive for respiratory and other distress. In COVID-19, this can look like a sudden and steep decline that can surprise patients, families, and even ourselves. In COVID-19, we have also experienced patients who looked like they were dying and then survived. This can make prognostication incredibly hard for everyone involved, and following patients closely is necessary to anticipate needs and changes as they arise. Early in the dying process, patients may be bedbound and have decreased oral intake and on and off wakefulness. For COVID-19 infections, respiratory patterns may start with rapid shallow breathing with cough and may progress to periods of irregular breathing with apnea and secretions. The late stages of dying will be characterized by a comatose state, cooling of limbs, mottled skin, and may or may not have longer pauses between breaths. Look out for signs of distress, including increased work or breathing, like use of accessory muscles or tripoding, and also grimacing, tearfulness, or moaning, so that we can appropriately respond. With family and caregivers in mind, many of whom may not be able to be present to their loved ones, we can take extra care to connect, either reaching out by phone or video chat if necessary to assess the need for education on the dying process, or for any religious, cultural, or unique rituals that would offer comfort, or for potential bereavement concerns. Keep in mind, this may require ongoing conversations and updates as patients' conditions can change daily. Foremost, at the end of life, we want to ensure the comfort of the person who is dying. So continue the responses we mentioned earlier in this module to address dyspnea, anxiety, agitation, and secretions. Also remember to assist with fevers and constipation, as these can also cause discomfort for patients with COVID-19. Here in the slides, we mentioned the core medications for each symptom. Tending to families and caregivers is also vitally important. Whether in person or by phone or by video connection, we can help the patient's loved ones by providing education and reassurance, giving them a safe place to express their emotions and facilitating connection and any rituals that may offer them comfort. Here's a guide to reassessing and titrating morphine at the end of life, particularly when they have a dyspnea and pain crisis. The principles here can be applied to other opioids who are also in a crisis. For more details, see the palliative care toolkit in our resource section. Let's now look over our titration. Step 1. Give your first dose. For opioid-naive individuals, this is around 2 milligrams IV, and then wait 15 minutes for its peak effect. If it's effective, order 2 milligrams every 15 minutes as needed. Step 2. If there's no relief, give an additional dose of 2 milligrams, and you may want to notify the prescribing clinician. Again, wait until peak effect, 15 minutes later. If this is effective, order 4 milligrams every 15 minutes as needed, which is the total dose titrated to achieve comfort. If no relief, move to step 3. Give a third dose that is 2 times the starting dose. Here we use 4 milligrams. Wait for peak effect. If this is effective, then you can order 8 milligrams, which is the total dose titrated to achieve comfort. You may choose to reduce this dose if you're concerned for side effects by 25 to 50%. If there's no relief, move to step 4. Repeat the 4 milligram dose and consider calling a hospice or palliative medicine specialist. Wait until peak effect, or 15 minutes. If this is effective, order 12 milligrams every 15 minutes. You may choose to reduce this dose by 25 to 50% if you're concerned for side effects. If there's no relief after that additional dose, then move to step 5. Give an 8 milligram dose, which is 4 times the starting dose, and at this point we recommend calling a specialist for help. Remember, you're trying to control for accessory muscle use and not respiratory rate. At any time, if there is a clear side effect, such as myoclonus, delirium, nausea, sedation, or even respiratory depression, it's important to reassess and determine whether an alternate opioid or reducing the dose will help and benefit the patient if it's aligned with their goals. After a patient dies of COVID-19, there are a few important care considerations that center around the deceased and the bereaved. In terms of postmortem care, caregivers may be asked by funeral home directors to take extra precautions to protect themselves, funeral home employees, and the wider community. These precautions may include placing a wet washcloth over the face of the deceased, shrouding the deceased body in a sheet, and placing their body in a pouch. Each of these tasks may distress caregivers, even those in facilities who are used to providing post-mortem care. Acknowledging the emotional burden of these tasks may be beneficial. It can be helpful to place our tasks within the ancient legacy of respect, kindness, and love that is caring for the bodies who have died. The handout in our resource section offers practical suggestions for easing the care process during the time of COVID-19 by both personalizing it and sanctifying it. For the bereaved, deaths from COVID-19 may elicit traumatic forms of grief due to the unexpected nature of loss and the possibility that a loved one may have died without their family at the bedside. Care teams can tend to families by offering empathy and ensuring that skilled bereavement support is available. Our resource section provides some printed materials on grief that can be given or mailed to families and their caregivers. Additionally, health organizations can work to make bereavement support groups available for all who have been touched by the virus and distribute lists of local grief counselors willing to be available for one-to-one support.
After Margaret dies, the team is distraught and disconnected. This is their third death this week, and Margaret's death particularly hit hard, not only because of the loss of her big personality, but also of the challenging secretion management. How would you care for your team members who are overwhelmed and exhausted? Write one answer you would do for yourself and one answer you would do for your team. Bronwyn will now speak to applying the whole person approach to caring for ourselves in situations like this.
As we have heard, whether we are in the role of care provider, patient, or loved one, COVID-19 challenges the well-being of the care team in all of the interconnected domains of our personhood. When we are overwhelmed, two things happen. Our bodies activate and our brains shift into low gear. Under extreme stress, the brain itself, usually humming along in a connected fashion, disaggregates into its emotional, instinctual, and rational parts. And the rational brain, usually able to influence the reactions of the emotional and instinctual brain, is paralyzed. When we are stressed, setting limits and committing to self-care across the domains is always a good idea. For Margaret's team, having experienced back-to-back deaths, one of which was traumatic, staying connected was not only helpful but vital. Checking in with one another, taking time to talk about the experience, these are necessary for processing. And under extreme stress, when people tend to withdraw, especially healthcare workers, connecting becomes even more crucial to maintaining resilience. No matter how challenging things feel, something simple you can do is take 1 to 2 minutes and ask each other, how was that? How are you feeling with that? In times of acute stress, we can also support ourselves by interrupting the stress response by taking a moment to integrate body, mind, and place right here and right now. The first step in this process is recognizing when the stress response begins. The second is creating a gap in the response before it takes over by calming our bodies and our nervous systems. This gap increases our capacity to adapt well to the needs of the moment. Here are a few of the many practices you might try. The 5-4-3-2-1 is a grounding method you can use anytime and anywhere. Looking around wherever you are, you can name any 5 things you see. A chair, a flash of light, 5 visible things. Next, name 4 things you can touch. Your shirt, the earth under your feet. Then 3 things you can hear, birdsong, creaks of the house. If you can hear your belly rumbling, that counts. Next, 2 things you can smell. Hand sanitizer, anyone? Last, how does the inside of your mouth taste right now? Toothpaste? Old coffee? Other grounding techniques such as taking 3 deep breaths, body scans, and mindfulness practices using acupressure points can also bring you back into your body and into the now.
Included here are reference links that can supplement this webinar. Take a look at your leisure if you would like to learn more. We would like to thank the following groups who have supported us in creating this webinar. University of Vermont, Department of Family Medicine. University of Vermont, Home Health and Hospice. University of Vermont Medical Center, Division of Palliative Medicine. University of Vermont Medical Center, Nursing Education. University of Vermont Medical Center, COVID Incident Command, and the Birchwood Terrace community. We're grateful for the opportunity to collaborate with these amazing teams of people.
If COVID-19 can teach us anything, it can help deepen our understanding of the paradoxical and promising nature of human connection. On one hand, it is our very interrelatedness that makes us vulnerable to viral transmission. On the other, because it shows us the great cost of social separation, the virus also reveals how important and natural in us is the draw to connect. At the individual level, the stress COVID-19 puts on us can pull apart our whole selves and weaken our capacity to adapt and sustain. Yet it also offers evidence of our deep reservoirs of resilience when the whole person is tended, not only individually, but communally. We hope this webinar will be helpful to you as you tend to those under your care and those who are beside you. And we hope it will help you better care for yourselves, the better to care for others. May you be whole and well.